Thank you. Thank you very much, Odeda, Dr. Odeda Benin. And thank you also for all your support to our work. For years, you have been working shoulder to shoulder with WHO operations in different parts of the world. And you know us very well. So thank you very much. And yes, thanks to Andrew for organizing it and all of you for listening in. I hope that we will have an interesting discussion. So today we are going to discuss the way we, WHE, work. And WHE is our way, the way we call our new WHO Health Emergencies Program. We are actually a child. We were established in 2016, but started working in 2017. And right now, working fully in many parts of the world, is assisting in many emergencies. The emphasis today will be at the nurses, midwifery, and the support that you and these teams have been providing to us, and we put them at the front of our work. So first of all, before we go to how WHE works, I thought that it will be good to understand what WHO does. And the first thing that everybody should ask themselves is, what is WHO? So WHO is a UN organization. We are under the UN umbrella. However, we have our own governing body, meaning we have different member states, an extra member state to that of the United Nations. We have our own constitution, and we work following the United Nations, but our role in the United Nations is leading health. Our constitution defines our functions. And as you can see, we are here to provide leadership on global health matters. And it's important to understand that our governing bodies are actually the member states. We are governed by all member states of the WHO, and each of them is represented by the Minister of Health, and each of the ministers of health of the world has a vote and decision in deciding what we do, how we do, and how we move forward. We are also very involved in shaping the health research agenda and mobilizing pragmatic and operational research and development, such as vaccines and other preventive measures, as well as clinical practices. And in that regard, we set norms and standards, and we articulate them based on evidence-based, so that member states, our ministries and government, will be able to make the policy options and the decisions based on the evidence. When countries need technical knowledge-based support, we are there to provide it to them. We also monitor and assess the health trends of the world. We have databases, and each of the countries is reporting to us on different issues. We, though, have another very important thing that we have to do, function, and that's provide the necessary aid and health services and facilities to special groups upon the request of or the acceptance of our member states or the United Nations, and through emergencies. And that part, the necessary aid and health services, that actually opens the gate for us to put people first and to take care of the people in the world, whoever they are and wherever they are. So the functions are really diverse, and based on the last one, the necessary aid and health services, the WHE, the WHO emergency program, was established. So why was it established? It was established because in 2014, during the Ebola outbreak, as many of you know, we, WHO in that regards, received kind of negative criticism and suggestions and other ways to criticize what we did in Africa. For that, our member states, our decision maker, the governing bodies, decided that we need to be better. Our Director General at that time moved forward and said that we have to work differently. And together with the best experts in the world, they established the new way of work, and that's WHE. They first looked at the risk factors of the world globally and specifically in each of the countries and assessed what kind of way we could do and what means we can provide to the countries to assist and ensure that lives are saved. So WHO in 2019, we summarized the 10 most pronounced threats to the global health. And here we have different issues. First one, which we all hear about today, is air pollution and climate change. And clearly, we know that this topic needs attention. Currently, 9 of 10 people breathe polluted air every day. In 2019, the air pollution was considered as killing 7 million people prematurely every year from different diseases that are associated with this. And around 90% of these deaths are in low and middle income countries. So meaning that it's not only in other countries, it's actually all over the world, and it's emissions from industries, transport and agriculture, as well as home, fuels in home, use of fuels in home. These are the largest things that we need to be prepared for. The second one is non-communicable diseases. As such, we have many diseases, including diabetes, cancer, heart disease, which are collectively responsible for more than 70% of the death, or about 41 million people. It includes 15 million people dying prematurely, aged between 30 to 69. And again, this will come when we will discuss how WHE, the WHO emergency program, works. Global influenza pandemic is another issue that we need to tackle and be prepared for. As our Director General says, Dr. Tedros, he says that the one thing that keeps him awake at night is knowing that influenza is on its way. It's not a matter if, it's just a matter of when. So we are sure that the world will face another influenza pandemic. And we are sure that the global defenses are as effective only as the weakest link in any country's health emergency preparedness and response system. For this, preparedness in general becomes a key activity of our new WHE. The other issue is the fragile and vulnerable settings. More than 1.6 billion people, which means almost a quarter of the global population, live in places where protracted crisis and weak health system leave them behind, leave them without access to basic care. These people, they are left alone with the circumstances where they were born to, while others in the world were fortunate to be born or live in other places. These fragile settings exist in almost all regions of the world, including the European region, and these are where half of the key targets in the SDGs, the Sustainable Development Goals, including on child and maternal health, remained unmet. Big issue, and we need to remember that when we come to our work. AMR, antimicrobial resistant, the inability to prevent infections will certainly seriously compromise surgery and procedures such as chemotherapy and other diseases. Resistance to TB pharmaceuticals, drugs, is a formidable obstacle to fighting a disease that causes around 10 million people to fall ill every year. These cases of drug-resistant and multi-drug-resistant TB exist in many countries, and in some countries more than before. In some countries, the multi-drug resistance are just becoming more and more prevalent. Ebola. We all hear about Ebola and other high-threat pathogens. Here, again, in 2018, just after finishing one outbreak, another one in the other side of DRC broke, and we saw those two separate Ebola outbreaks, both of which spread and keep spreading through cities of more than 1 million people. And what we see, and that comes again with these vulnerable and fragile areas, many times the outbreaks occur in areas where there are fights and some violence and lack of access to health services and lack of respect to human lives. It shows that the context in which an epidemic of high-threat pathogen like Ebola, it shows what happens when it happens in rural. In the past, it would apply to small populations, now larger populations with people movements, and due to the violence and war, we can hardly access many of these areas. Of course, WHO and our partners are working day and night to contain those outbreaks. And that brings us to the other hazard, which is weak primary healthcare. Primary healthcare is a key to health services. Primary healthcare is where people meet preventive services and care, including long-term care, chronically sick care, and community-based rehabilitation and other aspects. It's the first point that people contact and have their health care. And here, the health services many times are not dependent on physicians. Many times it's nurses or paramedic or nurse practitioner, depending on the countries. Primary healthcare can meet the majority of people's needs through their life course. However, in many countries, the health systems do not have primary healthcare that is strong enough, and if they do, it is not covering everybody universally. In each and our communities, in many of our communities, including in the European region, many people are left behind. These people, we have like big holes in the umbrella that should cover us. Vaccine hesitancy. This is something that became modern since we controlled many of the outbreaks lately in the past years. Many of the people, many of the parents become very, they believe that the diseases were gone together with everything else. They forget that we don't see polio today because of the vaccines, that in some countries we don't have measles because of the vaccines. However, we see that many countries do have enough vaccine coverage, but they still have pockets within the populations that are not covered. In some countries, it is due to hesitancy, to that belief that vaccines are harmful and they make more damage than good. With that, we see now what is going on in Samoa, in many European countries, including Ukraine, where the outbreak actually kills children. So in the European region, by the way, in May 6, 2019, we declared a multi-country grade 2 emergency due to the measles outbreak in many of our member states. Dengue. Dengue is a mosquito-borne disease that causes flu-like symptoms, but can be fatal, 1 in 5 of the cases. It is estimated that 40% of the world is at risk of dengue fever, and there are around 390 million infections a year. WHO dengue control strategy aims to reduce it, and therefore dengue is one of the diseases that we are tackling. And of course, we should not forget HIV. This year, WHO will work in 2018 with countries to support the introduction of different new and modern technologies. And one activity was announced in December 2018 by WHO with ILO that would allow organizations to offer HIV self-tests in the workplace. HIV is a disease that we are really putting lots of emphasis as we want it to move away from our agenda. So Dr. Tedros, that became our DG 2 years ago, developed the triple billion approach. And he said that every country's 2023 target is to contribute to the triple billion approach. And he said 1 billion of more people benefiting from universal health coverage. And universal health coverage means that every person on the globe will have access to quality, good quality, safe, seamless, continuous primary healthcare services and expert services as needed. That doesn't mean that people do not have to pay. We have to find the way how to fund it through taxes, through co-payments, but everybody should have access and money should not be the barrier. Also, he wants to see 1 billion more people better protected from health emergencies. And that actually brings WHE, the WHO emergency program, into one of the main 3 pillars of WHO work. The third pillar is 1 billion more people enjoying better health and well-being. And this is mainly prevention, nutrition, physical activity, and other health promotion activities. It is important to see that WHO is focusing on this 3 billion target. And I'm just trying to take that away. I see something happened here. We can see that many of this work is done through what we call the 13 General Program of Work. The 13 General Program of Work brings into life the vision of WHO, where we want to work so that all people will attain the highest possible standard of health and well-being, while promoting health and shifting the driving force into the country for the people and stepping up the leadership of the world. The leadership is something that is extremely important and needs to be strengthened. With the coverage, when we are delivering the vision, the universal health coverage that we are promoting today, also through the emergencies, is to allow all people to have access to needed health services of sufficient quality, to be effective with no financial hardship at any time. So if you look at the way we are working now, we have the 3 billions, and in the one that has to do with WHE and the way we work from now on, we put emphasis on 3 areas. One is countries prepared and for the health emergencies. So here, this one, 2.1, is actually putting emphasis on preparedness and readiness. The other one is being able to prevent epidemics and pandemics. And the third one is the response. So we are going from preparedness and prevention to response, which consists of detection, early detection, and responding timely to each of the emergencies in the world. While we work on this, we are also contributing to health promotion and universal health coverage. What we do in the European region, our member states agreed to sign off a document that we call it an action plan for preparedness and response to emergencies. And when we work, we are looking very closely to strengthen the health systems and to work on different principles, including country ownership, moving towards the SDGs, and strengthening partnership and intersectoral collaboration. Partnerships, as such with your organization and other organizations, are extremely important because WHE, we are a small group in the world. We need support from experts to join us and to come and work with us in a priority countries-based approach and building on regional framework. The WHE is working through all the phases of the emergency management cycle. So we are starting from prevention, preparedness, response, and recovery. It's very important to understand that when we work to respond, we already work side by side on prevention and preparedness for other emergencies, because as we said, while we saw that when we have, for example, floods or floodings or earthquakes, we see that outbreaks come and follow. When we have a war, yes, outbreaks. So things are moving side by side and you can never know. You start with one emergency and we usually end up with the other. So the key issue here is to work not only responding to the emergency itself, but working together with the complex interactions between health systems and emergencies. Clearly, every hazard can become a disaster, but every emergency is an emergency, but emergency becomes a disaster when the people were not prepared for it. They were not ready for it. And for that, we have to ensure that first of all, the health system will be strong. So our day-to-day work as WHE is to strengthen the weakest health systems, to prepare them to health emergencies that will anyhow further disrupt the health system. So we are trying to break that vicious cycle that goes worse and worse by building resilience, focusing on non-communicable diseases, mother and child and communicable diseases, working with preventive measures and public health, and emergencies related activities as mass casualty events, radionuclear and chemical events, etc. You see here PECs. PECs we call in the European region as people-centered emergency care services. So WHE, we are developing special packages of services that a country or a community should have in place in peaceful times in order to ensure that they work in times of disasters or emergencies, so that emergencies will not become disasters. The emergency, when it hits a weak health system, the vicious cycle, as I said, starts, and then it is very complicated for us to tackle it. So when we look from here, from the system, we want to move forward to the qualified health workers, because clearly health system cannot function if we don't have the right skill mix of people there. So what we would like to see, what we call as qualified health workers in the WHO emergency program, is a formally trained clinical provider, such as a physician, nurse, clinical officer, or medical assistant who has been recognized as such by a competent professional body in their countries. In terms of qualification in this context, does not refer to their qualifications in WHO. We are looking for the qualifications in the countries, but for that WHO is working with the countries to ensure that the standards are harmonized and globalized. When we look at nurses and midwives, for example, these people, these health professionals, they are key for our operations. They have a critical role in prevention, preparedness, response, and recovery. This is the largest group of health professionals that deal with critical care, management, and communication. And that's a key, because sometimes in some countries, nurses are not practicing or do not receive the right mix of education, or if they do, they are not used in that respect. So we will look at the nurses and midwives as critical care, management, and communication. Nurses work closely with the vulnerable groups most frequently affected by emergencies and disasters. They are well recognized and trusted by their communities. In many countries, the nurse that is in the community is the one that is taking care and knows the community very well. However, and that's something that we are working now really strongly, nurses and midwives are often left out of planning of emergency preparedness and response. And only rarely we find nurses that I am really fortunate to meet them, and I'm mentioning Odeda as one of the examples wherever I speak, but I'm sure that many of you do, that where we rarely see that the nurses are at the forefront, that they are also planning for the emergency, and they are not expected only to respond to it at a later stage. The issue that we are in WHE, we are trying to move is moving to emergencies from all hazards. So we are looking at the all hazards approach, because in most emergencies, the needed resources are insufficient or scarce, and we don't have enough workforce, we don't have enough people, and we are asking for volunteers and people to come from outside. Nurses and midwives must be called upon to take roles as first responders, direct care provider, on-site coordinator of care, information providers or educators, mental health counselors, and triage officers. If nurses are trained well, they would know how to deal with all hazards. And even if the nurse is a primary healthcare and is going through very routine simulation exercise, drills, and other teaching modalities, she or he will be prepared for these roles then and will be able to train others in their communities, and the continuum of emergency care will be kept. The safety is also a critical issue, because principles of infection prevention and control, what we call IPC, and other safety measures need to be emphasized during the work. And when we work with the nurses, we are asking all nurses to understand that there is a hierarchy of decision making and full detail of incident command and control management, and that communications should be in place. In many places where we work, the nurses are at the leading role, and that's great because they know how to do it. The nurses need to be able to function across a variety of settings. The use of personal preparedness plans to be developed and how we work in the field is very helpful. I'm sure that many of you heard of EMTs and GORAN. EMTs is the emergency medical teams that are classified by WHO, and GORAN is the global outbreak alert and response network of experts. We also have standby partners. All of them are registered in WHO database, and many of those providers of support are nurses and midwives. So when we have emergencies in many communities, we see that the nurses, as I said, are the first one to step in. If they were involved in preparedness planning and in response, they are those that know how to lead and be managed as needed. But we have to remember to also pay attention to the nurses, midwives, and other health workers to ensure the multidisciplinary work of the team while making sure that their houses, families, and life will be managed well, because each and every one has their own families and communities that expect them to help and be with them or support them. Also, absence of health information data and lack of personal medical history would put the health provider into real stress, because we get patients that we don't know their history, we don't know what they do. Also, the stress management of the incident itself. For example, we're just faced with the earthquake in Albania, and we know that many of the health workers needed to get support themselves. The intensified needs of disabled people and the chronically sick with non-communicable diseases, the need for medications, the need for food and basic issues, put those at the front for is even more a kind of stress. Increased in premature birth and exhaustion and stress are some of the issues. So all of those issues, all those challenges need to be trained and taken care by the system ahead of time. We have to know who is on call where, what to do with the families, how to care for the children of the nurses, midwives, and other health workers, and what to do with all other challenges that I just mentioned here. Clearly, nurses and midwives contribute to our emergency response, as I mentioned, leadership, the expertise, the know-how, competencies, training, education and research, care and follow-up. All of these are important because without each and every one of these, our response will be weak. Let me just go quickly through two examples. The one is our response to support Syrians, and in that regards, the United Nations has a resolution. We call it Whole-of-Syria response, and the Whole-of-Syria response allow countries neighboring Syria to provide support through very specific border crossings into Syria. We in WHO European region have access from Turkey through specific border entry points from Turkey to North Syria. We have an office in Gaziantep, and that is, by the way, the operations are led by a nurse, our nurse. So what we have there, that almost 4 million refugees have actually had to escape the war zone in Syria and arrived and are hosted by Turkey. And the beautiful, I think, real amazing flagship model that Turkey and WHO have been leading there is that more than 1,200 Syrian health workers were trained and certified to serve in the Turkish healthcare system, and they are those who provide the health services to their compatriots every day, everywhere. You see here in the photo, you see the nurses that are working in one of the areas. More than 433,000 free, culturally and linguistically sensitive health consultations have been provided in the past year to the refugees. So what is happening there? The refugees that came from Syria and were health workers in Syria were trained in Turkey by a program that was developed by us and implemented by the Turkish authorities to ensure that the universal health coverage system in Turkey will be culturally and linguistically appropriate for the refugees. In that way, all the health workers that were ready to work in Turkey were trained to provide those services. And this is one of the stories that we are very proud of. The other story is the protracted emergency in Ukraine. Again, nurses have been in the forefront. Now generations of multidisciplinary teams since 2014 have been strengthened their capacities in trauma and emergency care. And this was done and have been done through ambulances and cars that provide mobile primary healthcare units. Nurses and sometimes other health professionals have been visiting the communities in the war zone, providing access to essential packages of primary healthcare services. The WHO standards of care that were adopted for the local context have been later on used by the Ministry of Health of Ukraine when they developed the primary healthcare standards for the whole country. And that work is, again, the nurses were at the front. So what we see is that the nurses and midwives are a force for health, because we see the critical role in emergency preparedness at the local, state, national levels through planning, community and people-centered education and direct care provided during disasters. So the nurses become key if they are part of the planning, part of the preparedness, have their concrete roles, everything in the background is well maintained, even in the most simplest environment, those that are not rich. The nurses and midwives, as well as other healthcare professionals and workers, can do their work. The all-hazard training is key here, and we need to ensure that each and every one of us know how to assess and to plan prior to the emergency, respond during a crisis, and assist in mitigating the hazards throughout the recovery phase. For us, emergency nurses are not only nurses that are working in the emergency rooms. The emergency nurses are those that are responding to the 2 Ps and 2 Rs. It's prevention and preparedness, response and recovery. And for that, the nurses and midwives are key health workers of integrated multidisciplinary teams. One of the examples that I wanted to show is from actually Israel. The Israelis healthcare system benefits from teams of advanced professional nurses that are dedicated to managing the treatment of injured, both in routine and emergency mass casualty incidents. And we can see that the nurses there play an important leadership role in the multidisciplinary team, and that their place in the hospitals and in community, in planning and in responding and providing guidelines is key to us all. So with that, I would like to thank you all, to thank especially for the health workers among you, the nurses and midwives that always innovate, provide solutions, and contribute to making healthcare available, accessible, and affordable for all, and using emergencies as opportunities to build back better. Thank you. Thank you very much. Odeda, back to you, I guess. Thank you.
Thank you, Dr. Nitzan, for that very excellent overview of the WHO Health Emergencies Program and the role of nurses and midwives. We're now at the part of the presentation where we'll take questions from the audience. So if you would like to ask Dr. Nitzan a question, you can click on the hand icon and essentially raise your hand virtually, and I can unmute your microphone to allow you to ask a question directly to Dr. Nitzan. I do see we have a couple hands already up, which is excellent. Frank Summers, I'm going to unmute your microphone so you can ask a question here.
Okay, thank you. And yes, thank you for this very enlightening presentation. I'm calling from Toronto, Canada. I just wonder if you could elaborate a little bit on specifically how you see the expanded role potentially of nurses in responding to the very significant mental health impacts of disasters. What has been the experience of using nurses in that area or any other allied health professional? Because clearly our psychiatric manpower is somewhat limited.
Should I reply, Andrew?
Yeah, go ahead.
Yeah, okay. Thank you, Frank. Thank you for this question, and you're very right to ask it. Indeed, mental health is an issue that is challenging us in every emergency. And as I just said, a few weeks ago, we were faced with the earthquake in Albania. And it's impressive to see how even in that circumstances, mental health becomes the most prominent problem. So yes, nurses, and they are being trained in our teams, also in Ukraine and in Turkey, but now in Albania, to ensure to provide the linkages, first of all, triage, the basic treatment package, and assessment if more professional type of psychiatric needs are there. So yes, we have a package that we are developing now for the mental health, that nurses will be able to use it in the very near future, I think in a few months.
Thank you.
Okay, looks like we have another question from the remote audience. Dorothea, I'm going to go ahead and unmute your microphone. Are you there, Dorothea?
Yes, I'm here. Hello. Okay.
Yep.
Thank you very much for the presentation, Dr. Nitzan. And my question is, as you have a good insight in the European region, do you know which countries who are not in an emergency state right now are really developing programs to train their nurses for emergencies like that? If there is already across the region emergency programs going on for nurses training or not?
Yes, thank you. Thank you very much. We are now emphasizing and focusing on 15 priority countries that are organized around 3 hubs. One is Kyrgyzstan, Georgia, and Serbia, and around them are the 15 priority countries. So literally, it's around those hubs. And step by step, we are working on the preparedness and planning. And I don't know if you remember one of the slides, I mentioned the PECS, the People-Centered Emergency Care System.
Yes.
One of those packages is for nurses. And when we will start, and this is where we put the nurses and the midwives at the front, this will start in 2020 in our new program of work. So these will be the first countries. But if anyone is interested to learn more, please drop me a note, and when we tell me where you are. And where are you, by the way?
Yeah, sorry, I forgot to mention, I'm from Germany.
You are from Germany. So we work a lot with Germany, and Germany is also our donor. And I'll be happy to be in touch with those of you who would like to get involved.
Okay. Yeah, I will certainly drop you an email then.
Okay, thank you.
Thank you.
Great. Looks like we have a few more questions. I'm just going to apologize in advance. They're doing some work next door to the WADM office, so if you hear any banging or hammering, I'm sorry. Looks like we have a few more questions. I think the next one is Bonnie Kearns. Bonnie, I'm going to go ahead and unmute your microphone. You there, Bonnie?
Yes, I'm here. Thank you. Thank you for the presentation. My question is, you spoke about mental health training for nurses. Are you talking about psychological first aid? That course, is that the one you're talking about?
Part of it is psychological first aid, but it's wider. It's also looking at social issues and the other aspects. But yes, it is part of it.
Thank you. I forgot to tell you, I'm in USA in Florida right now. Thank you for the answer.
Okay, thank you. Thank you, Bonnie.
Okay, thank you, Bonnie, for that question. We have another question from Valerie Reska. You there, Valerie?
Yes, I'm here. Can you hear me okay?
Yes.
Great, thanks. So I'm calling in from a remote Indigenous community in the high Arctic of Canada, not too far from the North Pole, where Santa is getting his sleigh ready.
Wow.
My question to you is with regards to the role of nurses in the greater interdisciplinary team. Is there any strategies that you have come across or you may consider to implement with regards to the respect that nurses get from the other interdisciplinary team members? In my experience in emergency response, the role of the nurse has been downplayed quite a lot in favor of medicine, for example. Do you have any strategies or ideas about how to foster the role of the nurse in emergency response? And I do have a second question as well.
Yeah, thank you. So, the whole idea, I mean, what I try to emphasize is that, yes, we are developing. If you remember, WHO has already for some years nurses in emergencies. We do have this publication, but we are trying now to modify it and to put the nurses as an equal team member, and in many circumstances, the leading one. So, and that's exactly where we want the nurses to resume the role in planning and in preparedness, not only be involved in the response, because then nurses become the aid, and we want the nurses to lead. So we want already to establish this role, and for that we will work together with nurses, and we are now developing it as part of our PECs. I hope I replied.
Very, very much so. Thank you. My second question is with regards to mental health as well, and the role of, responder fatigue, basically. So, and although nursing would deliver for psychological first aid for the affected members of the population of the emergency, how does one, or how should nurses take on, caring for themselves? Because as most people know, nurses look after everybody else first and look after themselves last. So I'm talking about responder fatigue and responder crisis, for example.
Yes, absolutely. And it's unfortunately, it's not only nurses. What we see it in all our teams of health workers. We really forget to take care of each other and ourselves. And it's not that we forget, we cannot, and therefore we must. And we are saying now, again, like we say while we fly, that you have to put the oxygen mask first on the mother and then the child. It's easy to say, but what part of the teams that we are in this multidisciplinary team, we would like to have a nurse or someone that can capture these capacities and competencies that would take care of the team itself. And but it's not always a team member can do it. We also have to work in advance including taking care of the families and ensuring that everybody can really focus on their well-being while taking care of others. And I agree with you, this is again part of the PECs.
Okay, thank you for that answer. It looks like we have one other question here. I've exchanged a few messages with Francis. I'll go ahead and unmute your microphone. Francis, did you want to go ahead and ask a question? You there? Well, it appears that Francis is not there at the moment. So I did have a question for you, Dr. Nitzan. You had mentioned the importance of all hazard training.
Yes.
Could you give some examples of what you mean by all hazard training? Would that be simulations or I guess I was just curious if you could provide a bit more detail about what.
Sure. Yes, so all hazards, we call the different groupings and different types of hazards. So for example, you have natural hazards that could be floods and earthquakes and weather conditions, global warming, etc. We all have to be prepared for them. We have the biological hazards like infections and similar issues, chemical events, radionuclear events, and conflicts and wars, and other man-made disasters, and as well as cyber attacks, fires, etc. So hazards, what we call hazards, is the event that would cause the emergency. And sometimes we, in the past, many years ago, not many years, but some years ago, some people were expert in that or this field. It's okay to be an expert, but all of us, those are at the front, we have to be prepared for all hazards. And for example, even the cyber attacks, and what will happen to countries that depend on health information systems, on medicines and everything to be provided through a computerized program. Can you imagine what happens when it collapses? And we had some cases already in some countries. This is an emergency. Of course, different type of emergency, but we have to be prepared for that emergency as well. Andrew, back.
Dr. Nitzan, may I ask a question? Andrew, is there anyone else, or can I ask a question?
No, you're the last person, it looks like.
Dorit, thank you for wonderful highlights and presentation. And you mentioned in your lectures the pillars related to the involvement of nursing work, especially focus on preparedness and the response. And I know that this is the part that, especially the response, is a part that we are very much dealing with the emergency, and it's here and now, and it's relatively short phase. What about recovery? What about rehabilitation? Is this also part of the training, of the preparedness of the team itself, especially the nurses? Because if we are going to consider long-term treatment and help to the community, probably those nurses will be the one who are going to be there. So is there any program related to recovery and rehabilitation?
Yes, absolutely. Thank you, Odeda, for this question. Indeed, we are focusing on the full, what we call emergency cycle management, and it calls for prevention, preparedness, response, and recovery. And recovery is an equal partner. And actually, we start with the recovery during the response, and so the response triggers, again, prevention, preparedness, and recovery. Because in the past, we used to respond only during the response period. Right now, we push 3 buttons at the same time. And because we know that response to one emergency might require more, to be prepared for more and ready for more. Or not only that, in some of the emergencies, the readiness around that country, let's say the Ebola neighboring country, is there. But while we respond, we already need to recover. and the recovery here is with the health system. And therefore, we use emergencies as an opportunity to recover the system and the individuals. So not only rehabilitation of individuals, which is part of the health care system, but also recovery of the system itself. And that's exactly the key thing in the PECs, in this people-centered emergency care system, is that we put recovery already at the start of the response. And we have started this, I think now in the European region, we just started it, for example, in Albania. So we are doing the post-disaster. Right away, we started the post-disaster rehabilitation with the response.
Thank you very much.
Thank you.
Andrew, is there anyone else who want to present to ask something, or?
Looks like we got one last question here. Lynn Henderson just raised her hand, so I guess we can do one question in here before we wrap things up. Lynn, I'm going to unmute your microphone. You there, Lynn?
Yeah, I'm here. I'm in Nova Scotia, Canada. And as part of the recovery, would you also have strategies for building capacity and for further planning for preparedness?
Yes, exactly. That's exactly part of it. And as part of the recovery, we are closing the cycle from one hand, but also building back better. In many countries, we need to already start building back better and using the way we work, because many times during emergencies, we bring the expertise and the know-how and the readiness of the country to change the way they work. We want to build back better. So that's exactly what we're trying to do. But I hope that like in a year, we can meet again and then we can get your criticism and do it even better.
Okay, thank you.
Thank you.
Well, we are at the top of the hour. I think it's a good time to wrap things up. I would like to thank everyone in the audience for participating today. I know for some of you it's either late in the evening or early in the morning, or in some cases perhaps even the middle of the night. This was one of the most lively and engaging discussions we've had this year. So I really appreciate everyone asking questions directly to Dr. Nitzan. Sometimes people can be a bit shy, and so this was really, really remarkable to have such a great discussion and have so many questions from the remote audience. So we really appreciate that. I think it makes for a more interesting and engaging webinar overall. I'd like to really thank Odetta for making the connection with Dr. Nitzan to get this webinar organized and on schedule for everyone to participate in. We had a little bit of a conflict and tried to have this take place at the end of November, and I'm really, really glad that we were able to work it in right here before the end of the year. And then lastly, of course, Dr. Nitzan, thank you so much for taking your time and willing to share your expertise with the audience and, well, I guess with all of us. And lastly, the recording and the slides will be up later today. I'm planning to get this done and out and posted online in the next few hours. So we'll let everyone know by email that is now available. As I said at the beginning of the presentation, we're working on the 2020 schedule, so we'll be getting that out as we confirm presentations. And lastly, and finally, I'd like to wish everyone happy holidays and a prosperous and successful 2020. And I guess with that, any last comments, Odetta, Dorit, we can wrap things up?
Yeah. First of all, yeah, happy holiday and happy New Year's, New Year to come. And thank you again, Dorit, for wonderful presentation. You know, it's always wonderful to hear the side that makes the policies and not only to feel it on the field. So you brought it to us in a very interesting way and connected to the field. And again, Andrew, thank you for coordinating all this. And thank you everyone who joined us. And please, next year we're looking for more activities. So we'll be happy to meet you there. Thank you.
Thank you. Happy holidays. Thank you, Deda and Andrew.
Bye.